Ernest, let's start.
Good evening, everybody, and welcome to our March calendar of events. And today we have with us Professor Anindya Chakrabarti, who's going to be our speaker. And with him, we have Dr. Anthony Vipin, who is our co-principal investigator at IHOPE. And Professor Anindya will be talking about economic growth and health, an overview of theories, empirics, and policies. With this, I'll hand it over to Dr. Vipin to introduce Anindya and take us forward.
Thank you, Ernest. Good evening, everyone, and welcome to our webinar series at IHOPE. We have a very exciting topic today, economic growth and health. And I'm very pleased to introduce our esteemed speaker for today. Professor Anindya S. Chakrabarti is an associate professor of economics at the Indian Institute of Management Ahmedabad. He received a PhD in economics from Boston University in 2015. He is published in internationally reputed journals in economics and physics, such as the Journal of Economic Dynamics and Control, Journal of Economic Behavior and Organization, Quantitative Finance, Scientific Reports, Physical Review, and among others. His main research interests are in economic and financial networks, business cycles, empirical industrial organization, and geometry of networks and complex systems. He's currently serving as a co-chairperson of the Bridge Disa Center for Data Science and AI, and he's currently the UTI Chair Professor in Macroeconomics at IIM Ahmedabad. Professor Anindya, pleasure to have you, and over to you. Thank you.
Thanks, Dr. Vipin, and thanks, Ernest. I really appreciate this invitation. And so today what I will do is to talk about economic growth and health. And what I will also do during much of my discussion is that I will mostly show you some data and then show you some ideas, and then maybe we can have later on that discussion around it. And more like, I know that when I guess I was asked for the title, I wrote it as theories, empirics, and then policies, but it's going to be mostly empirical, and theories will be much more minimal. So what I want to get at during this next half an hour of discussion is fundamentally this idea that if we think about the importance of healthcare and mortality and so on, the key idea that I would like to convey today is that fundamentally it's quite possible that the historic disease landscape, what we see globally, and the initial healthcare system that has also been with us, or maybe from previous couple of hundreds of years, maybe that was actually one of the key reasons as to why we see the wide economic disparities today and all the correlates along with that. So this is the one idea that I would like to eventually zero in on by the end of this talk. Now, but before that, let me clarify a couple of things and let me set up the stage in order to get to that result and think about how to conceptualize these very different ideas of healthcare, mortality, economic growth, etc., etc. So let me just start from some basics, because given the fact that I think most of the people would be here would not be from economics background, and especially probably not so much from macroeconomics background. So therefore, I'll just lay out some very basic ideas, and feel free to stop me or write questions in the chat box. Roughly speaking, we can think of the economic performance of any given country at two different time scales. So one can be somewhat longish run process. So what we can describe as something like a long run growth, which happens over, let's say, centuries. The other one is something that economists are also interested in, is something that is known as short run fluctuations. So the idea of this short run and the long run it's a bit fuzzy. So that when we talk about short run and long run, it's not very evident that less than 2 years we will call it short run and more than 2 years we will call it long run. It's more like a concept, and I will show you how we zero in on the idea. But roughly speaking, the idea is that, let's say, something less than 5 to 7 years, typically we consider it to be short-run fluctuations during the time when we take most of the economic decisions at the country level. vis-a-vis something that happens over decades, if not centuries, we can describe it as something like a long-run growth. Now, let me just set up a couple of terms so that we see why we would even think that health is important for macroeconomics. So when this topic was given to me, I was actually I started thinking a lot about it, because generally speaking, at the high frequency level, which is happening, let's say, every couple of years and so on, generally health does not quite affect the economy at the macro level. It can affect a lot in terms of the micro level, what is happening in terms of disease. It can be very important expenditure component of a household, but all of those things are, technically speaking, what is called a part of microeconomics, not so much of a macroeconomic phenomenon. But on the other hand, when we think about the long run economic growth, and then what I'm claiming here is that there will be eventually a connection between health, mortality, and so on, disease landscape, and eventually the long run economic growth. Now, let's just zero in on some of the terms. The first important term that I would like to focus on is something like, what do we mean when we say that a given economy is growing? Now, by and large, what we really mean is that per capita GDP is increasing. So GDP is within a given geographic location, within a given amount of time, what is the total amount of production that is happening of new goods and services that are bought and sold within that region, within that amount of time. So it can be at a yearly level within India, or it can be even a city level GDP, city level production. So within a quarter, how much a given city is producing, and then therefore consuming, and so on. The way to think about how it relates directly to the more underlying variables is to see that this production is carried out in terms of two broad factors. One is something called labor, the other one is something that is known as capital stock. So, and the third component would be something that we will describe as technology. So the labor, for our purpose, for the time being, we can imagine all white collar workers, all blue collar workers, everyone combined together. That can be a labor force. They are working with this K term. So in this equation, this Y equals F of KL, this K can be thought of as a kind of a capital stock, which are all the buildings and machineries and everything that is used in a given production process. So in the context of a hospital, doctors and nurses and everyone will become part of M, and the buildings and the machineries and the equipment, everything will be part of K. And this F is considered to be something like how these two different things are combined together, which eventually leads to some kind of an output for the economy. And these things can be measured at the level of a given production entity as well. So it can be measured at the level of a given hospital, for example, that what is the total output and how are these different inputs are combined. Now, roughly speaking, some of the broad features that we understand very well now, let me define and get to the last point, that earlier we used to think that investment only in the capital, only in the capital stock is sufficient for sustained economic growth. Later on, we understood that that is not correct. So if people keep on just investing, or if a given country keeps on investing only in capital stock, eventually it will run out of the growth trajectory, possibilities, and then will hit a standstill. So some of the new things that we have started understanding is that health, for multiple reasons, will be a very important component of it. Roughly speaking, because healthy population leads to more active workforce who are, and I will elaborate more on this point, we will show that it will have a lot of spillovers on other types of decisions that a healthy population might actually make in terms of their own skill sets and so on, and capital employment. And the other thing that I would like to focus on going forward is something called institutions, which will be broadly defined political, social, and economic sort of the rules of the game that are there. So it will, broadly speaking, have all sorts of kind of patent rights, what kind of political systems are there, what kind of social systems are there, and all of those things we will describe as institutions. Just a visual in terms of what do I mean and what are the, roughly speaking, economic disparities that I have just talked about. So here on the left scale, in the left panel, what I have done is that I've downloaded some per capita GDP data for two countries, US and India, from the World Bank. The left one simply shows the time path of it. So as you can see that, and these are all in log scale. So roughly speaking, if you convert this into numbers now, so for India, it would be something like per year, per head, it would be roughly speaking, $5,000 of US GDP, whereas for US, it would be something in the tune of $60,000 to $65,000. So there is this tremendous gap between per capita GDPs that these different countries have. So India will be roughly in the ballpark of 5,000, and this is after accounting for all the exchange rates and everything. So it's not as if like if you just convert it into exchange rate and things will square. They won't. Now, over time, what we see is that US economy, it's obviously all of these countries have grown. This is the data from 1960s to 2020, roughly 60 years worth of data. And then what we can imagine is that for each of these countries, I'll not get into the details, but roughly speaking, what you can do is that you can think about there is a smooth component of growth. That is something that we will describe as the growth path. So here in this panel, there is a red line that I have plotted on this black dotted line. It's not particularly visible because one of them is kind of overlapping the other. But if you take this red line is called the growth path. How do I come up with it? For the time being, let's keep it aside. I am doing something called an HP, hot replace got filtered here. For the time being, we will not get into that. The residual of that is what I am plotting here. And this is what is known as the business cycle fluctuations. So for India, I am doing the exact same thing. And as you can see that for India, the fluctuations are way stronger than what you have for US. In other words, the Indian economy is way more volatile than US at the business cycle frequency. But now there are 2 points. One is that for our purpose, that is not the important part because we want to understand how different countries grow. But it's important from the policy perspective because most of the decisions are taken at the business cycle frequency. And all the budgets and everything that comes up at the business cycle frequency. So whenever the economy is doing very bad, then the government might actually cut down on healthcare budget. I'm just saying, I'm not saying the government is doing it. All I'm saying is it's possible. So, and what we want to show is that the implications can be generational, if not century long. So here, let me get to one interesting pattern, and this is something that has amazed me for a very, very long time. This picture is actually very well known. This particular one I have taken from a paper by Dalgard and Strulik. So what is being plotted here on the x-axis is something that is that is known as the difference. So as you can see that if we just go back here, pick up any given year, let's say 2020, we understand that there is this tremendous difference, right? So there is this huge difference in terms of per capita income. So let's say if we go by 5,000 and 65,000, it's almost 13 times. Now here, what is being plotted is that in the year 2000, what people try to understand is that exactly what explains this huge difference. There is a very strange irregularity that is there. In the year 2000, take up all the countries and see, geographically speaking, and how far they are from the equator. Okay, so both on the in the northern hemisphere and the southern hemisphere. Typically, it holds better in the northern hemisphere. So what you are plotting on the x-axis is the distance from the equator, and on the y-axis, what you are plotting is a proxy for growth. So which is in this case it's log of urbanization, but that's immaterial. You could have plotted GDP as well. Generally speaking, what you see is that there is a very strong positive slopes, and the exact same analysis is being done on the right hand side. It's only for the European countries. So what it means is that the further you move up from equator, the richer you become. Or put it in a different way, richer countries are, or the countries which are closer to equator are much poorer than the countries which are farther from equator. Now, the even more surprising part is that this gradient, so this is called the latitude gradient for growth. This gradient had flipped around 500 years back. So before 1500, that is called actually the great reversal of economic fortune. Before that, the richer countries were closer to equator. But after 1500, somehow this great reversal had happened. Whichever countries were very rich, they started sort of going down in terms of their prosperity, whereas the countries that were relatively very poor, they started getting much more stronger in terms of their economic performance. So what explains this kind of wide divergence? There are basically, broadly speaking, four ideas that people have talked about. And this is purely from the economic point of view. I'm sure there are many other literature which will talk about it from a sociological point of view and so on. From a roughly speaking an economic point of view, there are four dimensions that one can think of. The first one is called the luck hypothesis, that maybe the starting points between two different economies can be very close to each other, but then they can have very different paths. It's more of a mathematical point that I will actually show that might have a lot of important insights. The more commonplace explanations, the first one has been this geography hypothesis, that it's typically the weather and climate which affects productivity, agriculture, natural resources availability, and so on. And and geography also matters for disease landscape. For example, the countries which are closer to equator, they will have a very different disease landscape than the countries which are much farther from equator. The third hypothesis typically goes by the name of culture hypothesis, which basically says that beliefs, preferences, values, that can be very different. So in terms of whether people are going to work or not, etc., or work towards what purpose. So would they be interested in terms of savings, in terms of investment, etc., that can have a cultural origin. That's the third hypothesis. The fourth hypothesis, which is prevalent nowadays, and that is something that I would like to focus on during the rest of the time, is something called the institution hypothesis, that laws and regulations, which broadly speaking define our political, social, and economic choices, and they give us the periphery within which we have to play. So these are sort of the rules of the game. That determines what would be the starting or what would be the end point of an economy, given a starting point. Now, before I get into this institution hypothesis and show you why it matters, let me show you some data in terms of regularities that you can find between, let's say, healthcare, mortality, child mortality, etc., with respect to how rich a given country is. Now, some of the ideas that you will see here are actually quite intuitive. So what I have taken this picture from a paper that is recently published in PLOS ONE. But the picture is very intuitive, that you are plotting life expectancy on the x-axis and log GDP. So you see that the relationship is very positive. So richer countries have higher life expectancy. That's not particularly surprising. That is what usually happens. On the panel in the right, we have this U5MR, so which basically under 5 mortality rate. So for countries which are very rich, that this index is very low, which is again very obvious that countries which are richer, they have more resources to spend, etc. So therefore, child mortality is less. That is not particularly again surprising, but it's kind of intuitive. Now, this picture is in terms of cross section. So this is across different countries. Does it happen for a given country over time? The answer is yes. So this is a picture that is taken from, so Angus Deaton was a Nobel laureate in economics, and here's this very important, interesting review paper called Global Patterns of Income and Health. So what we are plotting here is over time, how per capita real GDP is increasing. So the per capita real GDP is being plotted on this portion, and the infant mortality rate is being plotted on this portion, and we are plotting the time series for India and China. So as we can see, that GDP per capita of India is this black thick line. This dotted line represents that of China, GDP per capita. So again, countries are getting prosperous. What is happening with respect to infant mortality? Both of them are going down. Now, much more so for China rather than India, but we can broadly see that in both countries, it's going down. So that part is fine. So again, what we understand is that over time, as the countries get richer, all of these problems tend to die away. Now, how do we conceptualize it as a separate issue? Now, let me also show you another thing, that there can be a distributional impact as well. The question is whether the poor are affected more or not. So conditional on the fact that a country is generally poor than, let's say, their richer counterpart, we understand that the healthcare can be worse. But within that country, can we see any difference in terms of tangible, healthcare access and so on, which can affect the population within the country differentially? So what we are plotting here on the x-axis is the out-of-pocket expenditure as a percentage of current health expenditure. So how much people have to sort of cough up when they are literally, they're trying to purchase some kind of an, healthcare service, if they have to see a doctor, a physician, and so on. So again, the richer countries typically have much larger, broader insurance coverage, as well as the government funding and so on, government transfers. Generally speaking, you see a very clear negative slope here, that the countries which are poorer, there the OOP part, which is out-of-pocket expenditure, as a fraction is extremely high, and which is very bad for the poor people. Not only you have much lower income to begin with, but whenever you are seeing a physician in order to cure an illness, the amount of direct transfer that that person has to make is also high. That is not accounted for, or that is not supported by a government transfer, or there is no, for example, an insurance scheme that this person can take help of. Now, here is a problem. So we understand that income is negatively correlated with, positively correlated with health outcome. And health, presumably, so when I started the discussion, I said that better, more healthy population presumably leads to, more income, because then you have a much more active labor force who can, work, etc., and who can be more productive. Now here we are flipping the causal channel. Now, if you look at this picture, what we see is that the life expectancy on the x-axis, where we are seeing is that plotting the life expectancy at the beginning of a decade, and on the y-axis, what we are plotting is the average annual growth in income in the subsequent decade. In other words, we are trying to find out which countries have very life expectancy now, and seeing whether these countries do very well economically going forward or not. So this is the opposite causal channel of everything else that I was talking about so far, that richer countries have more resources in order to have better health. And now we are showing that, at least, going by this kind of analysis, the countries which have probably better healthcare in future, they do better in terms of economic outcomes. So the question is then, how do we break down this thing? That does health lead to better economic prosperity, or does economic prosperity lead to better health outcome? Now, probably both, but something very interesting happened, that one of these most famous ideas that has recently, it's not recent anymore, it has been there almost for 2 decades now, that economists started understanding that there could be one way we can decompose this channel, and we can see whether health affects income or income affects health, and so on, and there can be a clear causal segregation in terms of this. So the idea was actually brilliant. It was the idea that, historically speaking, Europeans had varying degree of colonization across the world. And I mean, I'm just giving you a gist of the main idea. I mean, developing the full idea will take a much longer time. But roughly speaking, the idea is that Europeans went out to many different countries in the world where they had set up their colonies. And the early settlers of those European people, wherever they would not themselves stay healthy, they would have low expected lifespan, high mortality rates, etc. For example, equatorial regions, where malaria could be a new disease for them, and so on. In those cases, they will set up the institutions which are much more myopic in nature, and which would be what Asimov and Robinson describe as something called extractive rather than inclusive institutions. What does it mean? Extractive institution is something that a given, a political setup where resources are extracted and are sort of monopolized by an elite minority. Whereas an inclusive institution would be where the right for deciding who will make the decisions and so on, that is much more democratized and much more distributed. The power of taking decisions is much more distributed. And the institutions, once set, they persist for centuries. This is also something that we know of, and I will talk a little bit. So basically, the point is that whatever was the early settler mortality hundreds of years back led to the choice of the institutions that came up over time. Institutions persist for generations, which leads to this very wide economic disparity that we see today. This is roughly the summary of as to the basic hypothesis. And this is a very striking picture. This is again taken from Asimov Robinson's idea that on the x-axis, what we are plotting is the log of the settler mortality, basically in different countries. What was the mortality rates that these European settlers have faced? And in 1900, and after 100 years, how are those countries doing? So basically what we see is that after we account for all sorts of all other everything else, all confounding variables, all the econometric problems have been accounted for, what we see is that the countries where these settlers were facing a very high mortality rate, indeed, those countries, even after hundreds of years, were doing very, very poorly in terms of their income. The relationship is clearly very negative. Now, how do we conceptualize this kind of outcome when we say that, so one might say that, oh, hold on, so but this is like a leap of faith, right? So we are saying that, so settler mortality was there. If the mortality is very high, or if the healthcare system is very bad, very poor, in that case, they will set up an extractive institution. So they will essentially just extract resources and move out of the country, leaving the country in shambles. And then eventually what will happen is that somehow, and here I am making a leap of faith, that somehow it will so happen that countries continue on the same trajectory. And overall, there will be a divergence in terms of economy. So here, given that I do not have a lot of time, what I will do is that I'll just give you a very brief economic logic as to how these kind of things can be thought about. So one thing we know almost for sure is that there is this very high intergenerational correlation between economic and health status. What it really means is that people who are born in rich family typically tend also, probabilistically, also tend to be rich. And people who are, even in terms of health, in health status, who would be rich, typically their progenies are also rich in health status. So one of the arguments that people try to give in terms of thinking about exactly why does that happen, one of the ideas that people come up with is that people, if in a country where people are not particularly sure whether I will have a very long life or not, if the longevity is not particularly high, or let's say if I'm not very sure if most of the time during the year I will be just down with malaria or not, if that risk is there, then people may not even make any investment whatsoever in terms of any other skill building. So for example, in a very poor country where the healthcare is very bad, and people for sure know that beyond, if one lives beyond let's say 5 decades, that's more like a miracle, chances are very high early childhood educational investment will not occur, because in that case the idea is that you do not get the return on investment. There is a very economic logic, and there is enough proof that probably this has a lot of truth in it, that if I see that the mortality is very high or the healthcare system is very bad, not only that affects my decision about accessing healthcare, but it affects all of my other decisions as well, for each and every long-term decision that I might take. So what will happen is that the poor households then by themselves cannot escape the first step of this poverty trap, that I am expecting to be in poor health, therefore I'm not investing in anything else. If I don't invest in anything else, for example, education, in that case, I will not be able to increase my skills. If I do not increase my skills, I don't get enough income. If I don't get enough income, I am not being able to spend on health outcome. And therefore, I am still back in the square one. So therefore, this persistent disparity can actually perpetuate across generations. So what is I will skip the math because I guess I'm running out of time. What is the way that people then think about, what is the way to break these kind of cycles and traps of not only poverty trap, but also in terms of, health trap and so on, that, poorer households will lead to poorer health outcome, which will in turn lead to, poorer households again. The idea is that in that case, the government plays a big, massive role in terms of, breaking this cycle, because essentially the idea is that in that case, a poor country may not want to rely too much on market to take care of itself, because in order for the market to take care of this problem, people have to first have to have an expectation of longer and healthy life to begin with, which they don't have. If they don't have that, then none of the other things will work. So therefore, the government has to intervene. And what are the problems that we see globally of government intervention, even in terms of targeting or providing basic healthcare along with reduction of mortality and betterment of child health outcomes? So one of the problems that we see is that this is purely from a development economics perspective, that much of the government intervention often is spent on what is known as relatively expensive disease, like something like cancer and so on. So which happens typically not for very young people, much more for people who would be probably older than 50 or 60 and so on. So therefore, that might actually have a large chunk of the government expenditure. The other problem is that most of the people do not even know that the government subsidies and transfer these things can be there. So therefore they are not being able to access the benefits. And in reality, also in terms of empirical data, this has also been observed in multiple cases that the subsidies to health that are there. So it's often not the case that the government doesn't do its due. It does, but it's just that the allocation is done, but then it does not eventually reach the intended recipients. And for example, for Indonesia, this is a very old estimate, and now there are much more recent estimates. I'm just showing it just for the sake of giving an example that for most of the less developed countries or even developing economies, what we see is that the richest 10% of the richest deciles of the households typically get way more subsidies than the poorest households. So these are sort of the problems of failure of government intervention. So I will take Dr. Vipin. I know that it's 30 minutes already gone, but can I take 2 more minutes to close?
Absolutely, Anindya. Please go ahead.
Okay. So what I will now just show is that some of the trends in the Indian healthcare expenditure, and there can be larger debates around it, but as far as the broad features are seen, broadly speaking, it looks like they're in the kind of the correct direction. So if you look at the healthcare expenditure per capita or the government component, amount, so just in terms of magnitude, both of them are increasing at a pretty steep rate. And if you look at the fractions of the total current expenditure, one thing that is very interesting is that, so I got the data only for previous 20 years from World Bank. I guess one can go back even further. But by and large, the private component is sort of stabilizing at a value around, let's say, 64-65%. And there is a small but minute positive trend for the government expenditure component, which is important in order to rectify the market failures. And the other portion that is very interesting is that this out-of-pocket expenditure, again, is sort of coming down almost monotonically. Not monotonically, there are fluctuations here and there, but at least it shows a sign of coming down. So it's probably showing that even within the private market, probably the out-of-pocket expenditure component is sort of going down. So what it means is that probably the insurance market is maturing a lot, or the government is transferring and at a targeted way and probably in a very accurate way, which can actually crowd out the out-of-pocket expenditure. So both of them, based on our earlier discussions, probably both of them are absolutely in the right direction. As of now, for a country, LM, a kind of low and middle income country like India, it may not be optimal for richer countries, but from an Indian perspective, it can be actually quite useful. Now, let me just quickly summarize that some of the things that I try to tell you about is that often we take a forward-looking view, and here I have taken a backward-looking view and just seeing that whether the global prosperity or the differential in economic prosperity can be explained by healthcare and mortality and so on. And it seems like the current economic theory basically suggests that very strongly affirmative answer to that. And the other couple of big things that we have sort of gone through is that, one, there can be a lot of generational effects and traps with very, very large economic consequences. So just simply existence of products or services in terms of, let's say, medical products and medical services is not sufficient, because if you just just expect the market to work, it may not work, because people can have the people who are supposed to access those markets and so on, they may have very different expectations and they may not even participate in that market, which leads to worsening of the outcomes and kind of poverty trap and healthcare trap at a very low level. So there the government has to sort of intervene in those cases, and some very rudimentary indices, at least in the Indian context, seems to be probably things are in the right direction. I do not want to emphasize that a lot, because I am sure there are many other things which are also wrong and which requires a lot of thinking. But purely from a macro and purely from a kind of, decade long or even longer than that point of view, that seems like, some, glimpse of hope. And finally, just one thing that along with Chirantan, we wrote this article in Ideas for India called Only Germs This Time and No Guns and Steel. So this was a one based on the idea that Jared Diamond gave, this guns, germs and steel, about how different countries grow and how germs basically create much of the impediments or differences in terms of later on economic prosperity. This we wrote, I think, around 1.5 years back during the first wave of COVID, and that's the reason we say that only germs this time. That guns and steels were not traded; only germs were traded. So let me stop here. I'll be happy to take up questions, and thanks for listening to me.
Anindya, it's time to write a book. Germs, guns, but where goes the steel? Now there are guns also.
Yes, I was just about to say, did you guys have some prophetic paper 2 years ago? And now we do have guns and steel as well, where the world's going. Thank you, Professor Anindya. I'd like to thank you on behalf of everyone for sharing a very important concept, right? Because most of these things as healthcare providers, we are either not aware, but it's very important for us to be also mindful that we are all part of this larger ecosystem and the kind of decisions that affect both the healthcare providers and also people who are accessing healthcare. But Professor Anindya, with your kind permission, if you might permit me, I wanted to share some information before we go into questions from the rest of the group. So I will just probably share my screen to just showcase. I hope you're able to see my screen. Yes. No, I just wanted also our audience today to kind of, take a look at Gapminder. It's something that I've been following for quite a long time of Hans Rosling's work. But this particular, there are many parameters that you can mix and match, but specific to what Professor Anindya has basically shared, we're all talking about health, and he also mentioned about income and how health is correlated and, how it's all kind of one, ecosystem. So Hans Rosling, the late Hans Rosling, he kind of looked at life expectancy and he looked at income of countries. And this is kind of a 200-year beautiful kind of a visualization. And Hans is known for this. That every single year it kind of plots, the data, and you can clearly see where your country is and how countries are, evolving over the past century. Specifically, as even Anindya mentioned, that, the kind of shocks that the world gets, both the world wars or, any other major event like the pandemic, also kind of gives you a sense of how things would have, specifically changed. And clearly it shows that, countries with high GDP have higher, life expectancies and countries with low GDP, definitely they don't. So I think it's more important to kind of be mindful. And now when the graph stops here, you can see where our country is at about 71. With a 6820, while you can see Singapore is at 85.1 with a 94.6, and of course Luxembourg is again at around 83. So anyways, I just thought it'd be interesting for you to continue the exploration from Professor Anindya's talk, and also look at how this conversation is very important for all of us to understand that how do we drive information back to policymakers. And also, more importantly, we understand the relationship between economics and health and how it is important. One of the things, Professor Anindya, that I thought was very, very interesting is where the decisions are made in the business cycle frequencies, right? Which was a very great learning for me also, that, if you're seeing shifts in economy and how is the government taking those decisions and how it kind of affects generations after that. Because it takes time for both these decisions to be either implemented or the effects for them to be seen. So we can basically now take questions from our audience here. We have a question from Dr. Varsha Rati, who basically writes, does out-of-pocket expenditure and low premium improve health? And has it shown that increased expenditure curve in India? How much is the combined one in India? What is better form of expenditure? Is it out of pocket, private, or government, or combined?
That's actually an important question. The exact numbers, what is the combined number in India, that I do not know as of. I have to look up the data. But the bigger point I can tell you from a macroeconomic perspective, that whenever we think about different households, we think about making our allocations. In terms of how much we want to spend on healthcare, how much we want to spend on our regular consumption goods, and how much on all other possible things. And generally speaking, the way we think of households, think of ourselves as something that we would describe as risk-averse individuals or risk-averse households. We don't like, generally speaking, sudden spikes in expenditure. If possible, we would like to avoid that. And that's the whole reason as to why we even buy insurance to begin with. So the whole idea is that even if something bad happens during the good times, so it's like if you have some amount of income during the good times, you keep on paying a small premium, so your income goes down slightly. But then when the bad time happens, rather than the income sliding down by a very large amount, it will go down, but then it will be also partly offset by what the insurance company will be paying you back. So effectively what is happening is that through insurance, what we are doing is that we are trying to smoothing out our consumption and so on. So generally speaking, that's the reason why out-of-pocket expenditure is something that people would not like, because it's a risky component. Because whenever we are falling ill and so on, that's not a cyclical phenomenon. Generally speaking, all of a sudden I fall ill, and all of a sudden I have to then spend a large amount of money depending on what kind of healthcare facilities that I'm accessing. So people do not usually like that. What is the optimal combination? Very difficult to say. And this has been a major point of debate across different countries. In fact, during the Obama regime, and when it was getting to the next regime, this whole idea of Obamacare has been actually one of these big points of debate, that to what extent states should fund the insurance, to what extent people individually should fund their own insurance, etc. So there are two different ideas of this kind of funding that we think about. One is something called generational funding. So there the idea is that think of people who are currently present as young and old. So the idea in that case would be that the current young people fund current old people's expenditure. So when this cohort becomes older, then the newer younger cohort will fund their expenditure and so on. So that is one model through which it may work. The other one is something called pay as you go, that you pay for your own expenditure. So you keep on saving your money, or keep it in a pot so that later on when you require the insurance to come up, then you pay for it. So different. There is, truth be told, there is no clear answer. So within insurance, I mean, we have seen multiple studies in multiple different countries, but certain models work better than others. But one thing almost certainly that can be said is that this OOP thing is not something that people like, this out-of-pocket expenditure. They would much rather like to access formal financial market in the form of an insurance. And the problem of government and private services is that it's again very complex. We know that generally speaking, some of the private services can be fantastic. Some of the government services can also be fantastic, but generally speaking, people have certain stigmas in certain countries, around government provided healthcare services, etc. In fact, if I have to guess, I would say that in India there can be some idea that the general government healthcare systems can be less sort of efficient than private healthcare services. Whether that is true or not is a very separate issue altogether. So what is it that exactly that will work? I think the answer will depend very much on which cohort of people that we are talking about. It's quite possible that rich people would like to have a very different healthcare system to begin with than poor people. But globally, there is this new idea that is coming up that as far as possible, the financial umbrella in the form of insurance should be spread. Not only in terms of healthcare, that is also coming up in the form of UBI, universal basic income. That will probably not happen in near future, but that discussion is very much there. So long story short, the idea is that private markets will be there, at least in near future. Obviously they will be there, and they are very efficient, they are very innovative. but the government also has to step in terms of providing these basic services and so on. And much of the inefficiencies that we see in terms of government services probably can be countered by, healthcare insurance. Having said that, the US experience has also taught us that healthcare insurance can come up with its own challenges, because later on, who will supervise the health insurance companies? That becomes a separate question. So, long story short, I do not know any final answer to that. It's just very multifaceted.
Thanks, Prof. That was quite a detailed explanation. Right, our country basically stood out launching one of the largest health insurance schemes in the world, which is the Ayushman Bharat, right? Which basically also the main goal is the reduction of the out-of-pocket expenditure for almost 50 crore beneficiaries is what the government is targeting. So what do you see India headed into, right? In terms of, do you think we are on the right path? Or is this kind of, what can we learn from the West? What are your thoughts on where the country is heading at the scale at which some of these schemes have been envisioned by the current government?
That's a very loaded question. So I will try to sort of steer clear of some of the points that you mentioned.
Sure.
No, I mean, certainly, as far as the economic logics are concerned, there is a lot of, good things in it. That is certainly true. There is no denying that. The other thing is that often these are done for the poorest quarter of the economy, right? Or the poorest, people in the economy. So in those cases, the trade-off is simply in terms of the first order effects and the second order effects. So it's something like, let me give you a different idea so that I can convey my point. It's a very, hotly debated point whether transfers are good or not. And this transfer can be in terms of, let's say, monetary transfer or, transfers of goods and services. There are many nuances around it. Let's cut it. But the point is as follows, that if you give transfers, then you can crowd out other possible, work employment opportunities and so on. So therefore, productive investment often does not happen. So for example, the whole NREGA thing is almost certainly one can say that it never led to anything productive in terms of capital formation. So one just gets the transfer, does something, and that something maybe just digging up a pond or doing something that never led to any tangible capital formation at a massive scale, at the scale at least in which the whole work was done. But that does not necessarily mean that the whole transfer scheme was useless to begin with, because the first order effect is simply that at least people will be able to eat, if nothing else. So there are these trade-offs that will appear from a policymaker's perspective. Now, when this insurance thing comes up, as long as most of the people, and they have to also understand that insurance is there, and that is a very strange thing. I guess maybe being physicians, you would know it, and maybe you have seen it in your own experience as well. For financial services, for example, one of the big problems that we see in India is that people don't even know that those services exist. Or in the rural economies, they are often afraid of even accessing the financials, going to the banks and so on. So the financial literacy is, for example, very. So given that this Ayushman Bharat and so on, these are also financial services, right? I mean, these are healthcare related, but fundamentally, this is still financial service. So as long as they understand and they take the benefit of it, etc., as long as those things are done, it's probably very good. But then insurance also leads to certain problems later on, not right now, because right now the first order effects will outweigh pretty much everything else. Probably what often happens is that then only a few insurers become big, and then there is a market concentration among the insurers and so on. So then the usual story of those inefficiencies will come in. But probably as of now in the near future, that is not going to happen in the context of India. So long story short, it's probably a very good step in the right direction. I think so, but I do not want to sort of hang my hat on that argument. There can be certain things which can be wrong as well, but I think broadly speaking, I would say that it is a fair deal. Correct.
No, thank you for that. But also, as Professor Chirantan also mentioned, that the cross subsidization model, I think that is significantly kind of a social calling of certain individuals or organizations, but at the scale that we would like to do, definitely, I usually call it connecting the haves to the have-nots, which I think in a way definitely helps a lot of care providers to be able to provide care irrespective of whether they are able to pay or not. But of course, it might not be something at a scale that we would like to see. It's only basis on how certain individuals go on their calling. Thank you. I request any of our audience to continue to type in their questions.
Can I take up one point that Dr. Raja mentioned in the beginning?
Yeah, sure, please.
So Dr. Raja mentioned in the beginning that the GDP graphs are parallel for US and India. I just wanted to point out that those are in log scale. So therefore, what happens is that in the log scale, even if one is kind of exponentially increasing and the other one is also exponentially increasing, but at a very different level.
Correct.
Just because of log scaling, they seem parallel, but actually the outcomes can be extremely divergent. So in the 1960s, just to give you an idea, in the 1960s, maybe the GDP for India, just if we have to scale it, I don't know the exact number, but maybe it's around 1500. From that, now India has gone up to 5,000. Whereas for US, maybe the number was at 10,000 and now they have gone up to 60,000. So therefore, in level, the curves can look very different, whereas in log scaling, it may look just like two parallel lines. So that is just one thing. And the second point, Dr. Raja said that the BOP crisis led to the reforms and that did not have a lot of effect on the business cycle, which is true. And that is actually the problem that macroeconomists have, that or generally speaking, economists and policymakers have, that most of the economic decisions that are taken, they do not have an immediate impact at the macro level. Typically, they come up over, they take decades in order to sort of show the effect in full glory. So that is there. That is also there.
So I just want to comment, and once again, thank you, Anindya, for the excellent presentation. A lot of insights that we got today. I have a few questions and comments in multiple aspects. So while we look at the macroeconomic level, and Vipin mentioned about Ayushman Bharat, the overall outlay, I think it was 6,400 crores now, annual outlay, out of which I think only 50% is spent, 50% is unspent, right, Vipin?
Yes.
But even if the outlay is increased, that means the input, it doesn't necessarily mean the output is going to be better, which is what we are trying to achieve, right? Why are we talking health economics? Why are we talking big data? Why are we talking public health? It's to improve the health outcomes and health indices, some of which were shown in today's presentation, like mortality rates. But just by increasing the resource allocation, till last year or 2020, India is spending less than 2% of the GDP. But if you were to, let's say, pump in more money, unless we have output incentives, it's going to be a challenge. And what Chirantan has been posting, probably somewhat related to this, that if we do not look at the outcomes, the systems to develop the outcome incentives, we may end up in just spending more, and it just gets magnified. The health system or the health care which is being provided, what they call as under high value care or low value care. The low value care will also keep on increasing. With low value care pretty much means that when a treatment is not required, or non-essential treatment or non-essential investigations, they will also keep on increasing. So unless those systems are developed, the output side incentives, which Manoj Mohanan, Chirantan's friend from Duke, had presented very nicely in our IHOPE annual conference last year, it's going to be a challenge just working on the input side. And one of the best ways on the output side is, while we develop, look at audits and health outcomes, Obamacare, value-based. But one of the important ones is what the West Bengal Health Department for state employees, Dr. Mukherjee. I don't know if Chirantan remembers, we had an interaction with Jay Bhattacharya.
Anirudh.
Anirudh Mukherjee. So he had developed an excellent system. What it what he had developed is, as a system, is that the patient still had a say in the overall health exchange which was happening. It's basically a provider and a consumer, and that's where the out of pocket. Now, out of pocket doesn't necessarily mean completely out of pocket. So even in the health insurance, you can have a co-pay where it could be made substantial, but substantial enough, not too much that they get you below poverty line, but substantial enough that the patients are mindful and ask the health provider, why are you doing this? What's going to be my outcome? And if I don't achieve this outcome, you have the ability to question, and also the health provider has to be careful about providing low value care. So fee for service doesn't work in any system, and we need to have checks and balances. And overall, there is a lot more to discuss. But I think, Anindya, if you or Chirantan have any more inputs on the output side, output incentives, or value-based care, managed care, I think that's where we need to work a lot for our country.
Can I just add one more point to it, Dr. Vipin?
Yes.
So
Please.
one very interesting book that Banerjee and Duflo just wrote, just a couple of years back, on this code economics for poor times, or poor something, probably for poor times. So there they mentioned something very interesting in terms of motivating why RCT is important and so on. So they sort of alluded to the idea, as much as I understood, that typically people think of changing these economic systems or health systems and so on as something that requires a reform. So it has to be top to bottom change, and therefore which has a lot of cost in terms of uprooting an existing system and bringing in a newer system, etc., etc. And their point is that maybe that is useful, maybe not, but it's much more feasible to take small steps and evaluate the output, exactly as Dr. Raja said, that make an change in the input and then immediately evaluate what is happening to the output, and so on. So basically the whole idea was that let's break up reform in thousands of smaller steps and see whether each of them are working or not, and then cumulatively we will see whether it leads to the bigger change, etc., etc. So in terms of evaluation and thinking about how to change the process and what should be the input in terms of the modeler, so whoever is proposing such changes and so on, the point is very well taken. The specifics in terms of this particular system, I do not know a lot about. Maybe Chirantan can shed some light on that, or if he has some other thoughts.
My only light to throw is health is such a political tool that we may want to do one small little thing and impact evaluate, but the politician may say, just go away. So they want to basically earn short run and long run votes. Question is then, how do we depoliticize health and show them the path for their own private gains as well? I don't know. I don't have an answer to that. But if the politicians can also be shown, or there could be some constitutional amendment that makes right to health as a center point of all discussions in the country, I think India will do much better. That's.
So this is actually true regarding what Dr. Varsharathi has written in terms of as the age increases, whether people would have more disease and if the insurance doesn't cover. This is actually very important from a political perspective, because the voter bases can be very different, and this is actually now playing out in case of US. That often people are saying that the younger people are not getting job. Why would you have such a lavish insurance which is meant for catering to the older population? Whether that is a justified point or not is a separate question. But all I'm saying is that there can be generational cohorts who can have very different opinion about what kind of insurance and what kind of these things can be there, because people get their benefits at very different points of time, and especially regarding these kind of things, that younger people will not require it so much, but then older people might. So therefore the appeal to the voter base can be very different, and therefore politics may play a major role.
And that's where some of the advantages of payer and provider being the same also has it's a feedback loop. So if you have an insurance or a third party payer, let's say government, and there is a provider who is different, then the system will try to suck out all the money. Whereas if you have this payer and provider in the same organization or entity, you will have checks and balances. And you can incentivize outputs. So that's something which has to be looked at. But as you all mentioned, as a political tool, if you want to just in an election rally give numbers and throw numbers of crores of money being given to all families, then I think it won't have probably much impact on the health of the country. But yeah, we had a good discussion today.
Yep, thank you. I mean, I think I'll just kind of wrap it up. It's almost 8 o'clock. But then again, just to kind of add in the touch points, health political tool, yes. Professor Chirantan, I hope UK is still recovering from the spring statement and how everyone's, reacting to what was recently launched. Two, saying that, yes, 4 days ago, the government launched another announcement, 37,000 crores spent so far on Ayushman Bharat, and they claim that it has saved almost 1.5 to 2 times of what the OOP could have been. So agreed that there is not just your business cycles, but your political cycles also that will determine health. And as Professor Chirantan said, it should be an effort to kind of take this to a much higher level beyond, specific agendas or manifestos. So with that, what I think the think tank at IHOPE is trying to do is to help sensitize, the broader, population, and not just that, academics, and each one of you who've joined us today, on how important it is to think on this at a multidisciplinary angle. And that's why what we're doing with these series is to kind of, it's a first step in that direction. So looking forward to continue the conversations and also impactful research through the wonderful collaboration of our collaborators in IHOPE. And once again, this evening, I'd like to thank Professor Anindya for his valuable time to start this amazing conversation, and everyone who has contributed to, sharing their thoughts and insights. So until we meet again, take care and have a wonderful weekend. And thank you once again for joining us for this webinar series of IHOPE. Thank you and good night.
Thank you, Dr. Vipin. Bye.
Good night.
Thank you all.
Thank you. Thank you.
Thank you very much. Bye.
Vipin, can you call me?
Yes, Dr. Arun, I will. Thank you.